ACO Global Development Awards competition is an award scheme that has been going on for 25 years, thanks to the generous support of the Ministry of Finance of the government of Japan, and of course, the critical support of the PHRD Trust Fund at the World Bank. This specific category, the MIDP, so Most Innovative Development Program, has been running like the ORD, Outstanding Research and Development Award, since the beginning. But unlike the ORD, this is a grant that goes to NGOs that are implementing projects. So this is not a grant that's going to researchers working on development. It's actually a grant for implementation. This was born at a time where faith in the capacity of states to figure out the new and successful approaches to development had faded. And this kind of competition was created to comb the planet for interesting and innovative ideas on how to tackle the most pressing development challenges to benefit the most marginalized communities. Since it's an implementation project, implementation award, the length of the awards is slightly longer and the amounts are also different. We're still talking about NGOs based in low and middle income countries that compete every year globally to get the awards. The unique feature of this award is that there is a follow-up grant. So we have today 3 finalists, and 2 of them will be ranked first. So we have 2 first prizes, which is quite unusual. And then we have a second prize. So we have 2 first prizes of $30,000 each, and then a second prize of $25,000. Now, the 2 first prize winners will compete in 1 year for a top-up grant of $200,000, right? So these are all projects that have already started. So if you want, this is a proof of concept with a lot of support from GDN that will lead one of these 2 projects to a scale-up phase with a top-up grant of 200K, which is called the GSDF grant, the Japanese Social Development Fund grant. As for the ORD, our job is not just to pass on the money. We accompany, the whole selection process is actually very strongly oriented towards capacity building. So everyone, whether they are selected or not, receives very detailed feedback on the proposals. People are invited and can participate in webinars. The finalists actually go through several rounds, and we will see in the next slide several rounds of checks and selection. But we also invited in the days before the conference, before the finals, so this happened last weekend, to a 2-day communications training, which is run by us, that wants to kind of level the opportunities of the 3 finalists to actually express their idea in the best way possible. The theme is very similar to, of course, the ORD, because this year we're focusing on universal health coverage and its links with digital transformation. This is a quick overview of the eligibility screening, of the evaluation process, starting with an eligibility screening, which is done in-house, a desk review of the eligible applications, which is followed by a business review. So there's an external consultant that goes and checks, does a compliance check on the NGOs to understand, to vet the capacity to implement a grant of this size, also in view of the potential top-up grant, which is much larger, of course. So due diligence, and finally, we go through a check of environmental safeguards of the World Bank. So we are fully compliant with the donors' rules and also the rules of the World Bank. These are the evaluation criteria. So if you see there's emphasis on the innovative quality of what is proposed, the clarity of the development objectives that the project is aiming to achieve, whether these objectives are actually measurable. But there's a whole extra set of criteria about the scalability of this grant as well. Because again, the idea here is to identify development approaches that can be scaled up and eventually taken up by the primary duty bearers in terms of development, which are, of course, our government with the support of development finance institutions. The jury for today includes 4 people. You'll see 2 familiar faces from yesterday's jury, and those are Jean-Louis Arcand, president of GDN, and Kiran Pandey, who's executive director at HAINet, and a health expert. Then we have Julie Biau, who's our contact point at the Trust Fund at the World Bank, who's joining us online. Welcome, Julie. And then, of course, we have Hideyuki Shiozawa, who's the director of the Division of Island Nations at the Sasakawa Peace Foundation. For those who were here in the previous plenary, he was, of course, part of that plenary. For those who were here yesterday, you know, oh, well, these are the criteria that the jury today will use to assess the projects. Of course, we have access to the full proposal, so most of the evaluation is done, but we are going to add to that evaluation the quality of the presentation. So the jury will meet right after the finals to deliberate on the awards. We have 3 finalists today, so 3 projects and 3 NGOs. So the first project is a proposal by the Dreamlopments Foundation, and we have the project director, Nicolas Durier, with us, and is looking at well, what we propose is a Migrant Fund, so a low-cost, not-for-profit health access fund for migrants, refugees, and stateless people, persons. Then we have the Greenstar Social Marketing from Pakistan with Dr. Sana Durvesh, that will, well, we'll hear more from her, but she focuses on last-mile workers through a self-sustaining digital ecosystem to transform reproductive self-care. And then we have Enrique Santos from Brazil at the Instituto de Inteligência Artificial na Saúde, that is going to talk about artificial intelligence to improve patient safety. More information, of course, on our website. And now let's get started. The drill is the same as yesterday, 15 minutes of presentation, strictly. I'll give you a sign, give you a signal when you have 5 minutes left, and then 10 minutes of question and answers with the jury and with the audience if there's any question. Okay? So we can start from Nicolas. So the jury is just sitting on the first row so we can actually see the slides better. Nicolas, you have 15 minutes. The floor is yours.
Thank you very much, Francesco. Good afternoon, everyone. I'm delighted to be here and to have the occasion to compete for this award. On behalf of all staff in the foundation, it's a pleasure for us to present the Migrant Fund, or the M Fund, a low-cost, not-for-profit health access fund for migrants, stateless persons, and refugees. There will be 2 parts in my presentation. In part 1, I will tell you about the context, the history, the design and achievements of the project from inception until now. And in the second part, I will tell you how we will propel M-Found to the next stage, to the next level with this award. Part 1, the context and the health problem that we tackle. In Thailand, the government has achieved 100% universal health coverage for Thai citizens. There are in the countries about 3 million registered migrants, legal migrants, and these people are entitled to 2 government health insurance schemes. Now, in practice, only 60% of them are effectively covered, which leaves 1.2 million people who are not covered. And on top of that, there is about 1 million unregistered migrants who are not eligible and who have also no health protection. And typically, these are migrant workers who contribute to build the economy, and yet they have no health right. This is just the context of Thailand. And around the world, there are actually many millions of migrants in different countries, different regions who have also no health protection. In this context, We have set up the M Fund as a low-cost, not-for-profit health insurance, health access fund for persons not covered by insurance schemes. This is to empower this population to self-establish sustainable and affordable access to healthcare services, to close the gap of universal health coverage in Thailand. And from the outset, the vision was that if it works in Thailand, then we would envision to extend M-Found to other countries and regions where similar needs exist. This is the map of the implementation of the project as of now, and it all started in 2017 in Mesot City, in Tak province, pictured in yellow highlight, along the Thai-Myanmar border. And from the start, it actually worked. There was a strong demand, strong interest and uptake, and we gradually expanded the project in that province and then in other provinces along different borders. It includes actually operation in Myawaddy, in light orange on the Myanmar side of the border, as well as in Poipet on the Cambodia side of the border, because many of these people are actually cross-border and they need protection on the two sides of the border. Overall, in all these provinces, we have formal agreement with more than 250 hospitals and clinics. Most of them are actually Thai public hospitals, and you can see in the different shades, blue and orange are provinces where we have staff and office on the ground, but we also reach people online where we don't have offices in many other provinces in the country. This is the way it works on the ground. Starting upper left, we have a team of community workers. You can see the lady at the center with a white shirt. This is our staff, community worker from the migrant communities themselves, trusted by their peers, speaking the language. They go in the communities and they explain what the M-Found is all about, either in households or workplaces or community center. Up right, bottom left, you can see people who are interested, and this is a voluntary scheme. People who are interested can sign up on the spot with the M-Found digital application that we have designed. You can see a phone screen shot here to the left that community workers can use on their tablets or on their smartphone. We take as an identification, bottom right, a picture, because most of these people do not have any ID document. We take a picture. There is then a health questionnaire and a membership agreement form that people need to sign. We collect the contribution. Most of these are in cash because these are unregistered, unbanked persons. All these transactions are captured in the M-Fund application. At the end of this process, there is a digital membership card that is in the system, and that is linked to a QR code which we give to the members. They are told where they can then access healthcare services. They present in the healthcare facilities that are partnered with us. They show their QR. The staff who are well versed with this system will scan the QR, and then we'll see the membership detail in the digital card. There are lots of details on this card. Just to show you, on the upper right corner, the green button active means that that person is actively covered by M-Found. Those people are given access to the services. They do not upfront any payment. They receive healthcare. The hospital will record these events and send us the bill at the end of the month. We verify these bills and we make payment. This is the M-Fund plan, as we call it, of contributions and benefit. I'll walk you through this. Starting upper row here in green, the base plan, as we call it, for people who have no pre-existing health condition. We request a contribution of 130 Thai baht per person per month. This is tailored to the ability to pay, which is about 3.4 euro. To give you a reference, an average day of work is about 200 Thai baht. So this is below 1 day of earning. We have then some options. I'll jump to the senior option for people above 50 years old like myself. We ask them an additional contribution. It's a total of 230 Thai baht. And we asked them to actually come with 2 other persons to have a risk pooling, risk sharing. We have an option for women who are pregnant, pregnancy option. We have an option for people who have chronic diseases, including existing chronic disease, and we cover pretty much everything. We have very few exclusions. The objective is to maximize access and coverage of healthcare services. With regards to benefits, we cover both outpatient, OPD, consultation, and inpatient department admission, up to 5,000 Thai baht per year for outpatient services, and up to 45,000 Thai baht for inpatient services. An average consultation is about 800 Thai baht. This is well below what we cover, and an average admission is about 10,000 Thai baht. So we cover well above that. This is a graph of the enrollment from our application, from the dashboard, and from inception to October, we have enrolled voluntarily more than 100,000 members, 60% of whom are women, many are pregnant women, and 25% children. In terms of coverage of healthcare services, we have up to now covered 164,000 outpatient consultation and more than 21,000 inpatient admissions, again on a wide range of illnesses. This is a graph from our application on cost ratio. This is a little bit busy, but in blue bars and purple bars, this is what we collect from members. In orange bars, this is what we pay to hospitals in healthcare services. And you can see that over the years, there's always been a gap. But in the last year, under the plan 5.0, as we call it, we have different iterations and improvement of the plan. We basically now cover all cost of care with member contribution. And this represents 65% of all cost of the project, which are being covered by member contribution. We are 65% self-sufficient with member contribution. In terms of partnership and support, these are just some pictures that illustrate the MOUs that we have with different provincial health offices and hospitals. These are pictures from an important meeting last year, National Migration Health Working Group led by IOM, where 2 prominent persons from officials from the Ministry of Health acknowledged publicly in this conference the place of M-Found and the place of M-Found, especially among the different schemes in Thailand, alongside government schemes to provide health protection for migrants. We have a video of testimonials from members, many testimonials. I couldn't, for the sake of time, show this video, but just as an example, here we have one member, a woman from Myanmar who's been with us for some years and who illustrates why it's so important for her to be under M-Found. In part 2, what will we do with the award? Well, with the award, we will extend M-Found in Malaysia, reaching a critical milestone in our vision of making M-Found a global solution to pressing gap of UHC. This will start in Penang State. The situation and the context is pretty similar to what we have in Thailand. We have 192 refugees and about 3 million migrants. Registered migrants, once again, can enroll in a government scheme, but only people from 18 to 60 years old. That leaves many people who are not registered, and this has been documented in many studies, and it's estimated that over 1 million migrants and refugees have no health protection. And in this context, we have been exploring the needs and possibilities to extend M-Found for this population. We have conducted multiple visits. We have MSF, Médecins Sans Frontières, Doctors Without Borders, has strong interest in the M-Found. They run a clinic for refugees in Penang. They have helped us to organize focus group discussions with the community. We've gathered very strong interest for the scheme. We have met with the Penang State Health Authorities who acknowledged the gap and expressed strong interest, and likewise the UN organization. We finally met with representatives from 4 key ministries, the Ministry of Health, the Ministry of Home Affairs, the Ministry of Foreign Affairs, and the National Security Council, who all have expressed interest and support for the project. In summary, the needs and relevance for MFund are clear. There is broad stakeholder interest, and we have secured interest and support from several ministries to pilot MFund in Penang. Therefore, our proposal to the GDN, well, the rationale is that although we are moving towards financial sustainability, we still have a 30%, 35% financial gap. Malaysia is new territories for us, and we gathered that the cost of care may be higher than in Thailand. We bring a robust, innovative solution to a critical UHC gap. There is very little international donor interest in Malaysia, and therefore we really cannot fail to deliver this solution in Malaysia, and we need the GDN MIDP financial support. The project will be structured in 3 phases over 15-month timeline. In phase 1, we will set up an office and team. We will adapt the MFund plan to the context of Malaysia. We will adapt our digital solution to the context with the currencies and other details. In phase 2, we will do community mapping, awareness campaigns. We will sign MOUs with different hospitals, establish partnership, plan to enroll up to 500 members. In phase 3, we will tune the operation and aim to enroll up to 3,000 members, share lessons, and plan for scale-up in other states. I'd like to acknowledge some funding members, institutions that help us and support the gap that we have. I'd like to acknowledge all the team and staff who make this project. You have here actually all organization staff with the other project. And I will leave this take-home message while I take questions. Thank you very much.
Great, we're actually full. There's two extra minutes. Okay, questions. Can I invite the jury members first? Jean-Louis?
Merci pour la présentation. Thank you very much for that presentation. So I have a couple of questions as an economist. So in terms of in some sense, it's a 2-part question. One is from the demand side, one's from the supply side. So from the demand side, do you know what the price elasticity of demand is? The price elasticity of demand, l'élasticité prix de la demande for the demand for these various health services. So I just want to get a clearer idea of how you determined your pricing policy for the various plans that you're providing people, and you know who takes up, who does not take up, because take up is the key here. So in other words, could you price these things higher to achieve sustainability? The second thing is, how do you decide also on those prices from the actuarial standpoint? Because you have your revenues and then you have your costs, and so you have to know, you know, how many people are actually then going, once they sign up for your plan, how many people are actually going to fall ill and have the doctor's visits and everything. So does this come from actuarial tables? Are you just asked, did you eyeball it? Which there's nothing wrong with that, right? Because maybe that's why you were making losses initially, and then you figured out, you know, you got better data or whatever, and then that's why you're breaking even further on. And then this is just out as a micro development economist, the sort of the second part to that second question is, so you're talking about risk pooling, which is completely reasonable. So how did you come up with that idea of doing the risk pool for the risk pooling for the seniors? I think it was the senior plan, right?
Seniors, chronic and pregnant.
Merci pour la présentation.
Thank you very much. So the answer to question 1 and 2 are actually related. So yes, we have not come with this plan out of the blue like this. We actually conducted extensive analysis. We studied cost of care, we studied morbidity, mortality data, we engaged with hospitals, we looked at pricing from the health government system. We did surveys among migrants about daily income, willingness to pay, ability to pay, how many people they would want to cover in a household. And of course, all of this was fed in systems run by actuarial experts, so micro insurance experts, who came to do those models before we launched the project in the feasibility study, and then who along the way came several times to analyze the pilot data and refine the plan. We have now the 5th iteration of the MFund plan, and this was all modified based on that. We also have extensive community engagement. Our community workers are from the community. So we engage with the migrants themselves, with the members themselves. And remember, this is a voluntary scheme. So we engage with them, and each time there is a change of the plan, we have extensive consultations with our members about what's acceptable, why it's needed, and so we make those plans based on that. And your last question was the risk pooling. The risk pooling. So initially, we were welcoming people with chronic diseases and pregnant women, and only them. I mean, we welcomed everyone. But we said for those who have chronic diseases, seniors, pregnant women, we said, well, you know, this is a health insurance scheme. Some of this is new. So we'd like to ask you to bring other members with you. They were not doing it. So in different iterations of the plan, we introduced a mandatory component in a voluntary scheme to address the adverse selection. And this is why now, with people who have existing health condition, we ask them, please bring 2 other members. It's a mandatory requirement.
Thank you very much. Also looking at Julie online, please come in.
Yes, thank you very much. I was interested to know a little bit more about the results measurement of, you know, what results you intend to achieve with the specific, you know, the funds from the award. How would you track the impact? And then the other question I had was with the pending. It's very encouraging to, well, first of all, thank you for the very interesting presentation and a very inspiring model. And for also consulting with the national authorities and local authorities. I noted from the project documents that there was a regulatory approval from Bank Negara Malaysia that was pending, and I wanted to check, you know, do you see that as a risk, or is that very likely? So what's the status on that? Thank you.
Thank you very much. So with regards to the first question, so the financial gap that we have of about 35% is essentially the operation, the staff, office, communication, the IT platform. So in the award request and proposal, our budget essentially covers those elements. In terms of milestones and outcomes, well, we have different indicators based on each of the objectives. So the indicators will be, well, how many people have been enrolled in the different phases, how many MOUs we have signed up with partner facilities, how many health events we have covered. And then it goes way beyond that for us, because we have in the dashboard actually multiple graphs and table, real-time data that we continuously analyze. Then we have in the database itself multiple data and variables on the characteristics of the members and on the plan they take and on the services that they use. And we can do some deep analysis of these indicators, either by ourselves or actually by the actuarial experts that come to help us. And with regards to the regulatory aspect, well, we were suggested by the different ministries to apply for the regulatory sandbox, which we discussed it this morning, from Bank Negara Malaysia, because the central bank is essentially the regulator of the insurance sector in Malaysia, and they have sent us a formal determination that that we are not an insurance scheme and we are free from that regulatory aspect. So we are now left to sign an MOU with the health facilities and health authorities to implement the project.
Great.
Thank you very much for the update, and merci encore pour l'excellente présentation.
More questions from the jury. Mr. Ida, yes? Please.
I have 2 questions on the operation. Do they, so unregistered refugees, they don't hesitate to be known by authorities they are in Thailand, in Thailand's case? That is one. The second question is, this fund also covers the level of treatment like a stroke, heart attack, or kidney problems, those kinds.
The answer to the first question about refugees in Thailand, there are 3 million migrants. They are, of course, in the communities. They work for most of them. There are refugee camps. There are refugee camps. And in these camps, healthcare services, water, sanitation, education has been provided by NGOs for the past 35 plus years. 100% 100% dependent on donor support. There's been a crisis in the past few months with disruption and interruption of US government funding. Most of these services have stopped. The Thai government has now, with other partners, has asked us to participate in this solution and to introduce M-Fund in the camp. So that's for the first question. Your second question, I'm blanking already, was, your second question was, yes, the coverage, we cover everything. We cover everything. There are few exceptions, few exclusions. We do not take people who have late-stage organ disease, liver failure, end-stage kidney disease. We do not take people who have severe congenital abnormality. Typically, that would be a child born with a heart defect. We do not take those people. Last exclusion, we do not take people who have existing cancer, who basically come to us and say, I've been diagnosed with a cancer, can you please help us? We'd like to, we cannot. We cover now all these conditions once they develop. If someone develops a cancer while being a member, we cover those care. Stroke, myocardial infarct, mental illness, HIV, tuberculosis, we cover everything.
Great presentation, Nicholas. I had two questions. I think the first question I had around was the benefit package, and I think some of it you already covered. Still, are you the guys who are deciding the benefit package? Does it match the government insurance program? Or if you could shed a little more light on that. The second question I have around is, as you look to scale up around sustainability, and I see two distinct risks. One, you're now going to operate in an entirely different jurisdiction that comes in with its own health system, own laws, and own risks. So how do you see that as a risk going forward? Second, also, as you look to scale up, I think you mentioned it in your application earlier in your presentation as well. Sometimes the cost ratio has been as high as 4. You could probably absorb that kind of risk when you have a few thousand people that you're taking care of. But if you have a lot of people, and if your cost ratio goes much beyond your collection, how are you going to take care of the risk like that? I don't think you're reinsured, so how's that going to work? I guess you're going to pull into your pockets, but I would imagine as a nonprofit, there would be a lot those pockets either, yeah.
With regards to coverage, we cover pretty much everything like the Thai government schemes. There is one significant difference with the government scheme for registered migrants and for people who are registered is that the government scheme has no limit of coverage. We do have a limit. We can't cover just everything at no limit. And so in the cases that exceed our coverage limit, actually the hospitals absorb the excess because they want to support the viability of the scheme because there is already a financial value for them of that scheme. So that's to address the first question. With regards to the pool, it's actually not the size of the pool that matters most for us. And this was in the initial models that we run. If we reach 50,000, we'll be self-sustained. That has proven to be actually not right. What is most important is what we cover and what we collect. There is actually one particular group of members who cost us the most. It's actually women who are already pregnant when they join the scheme. There is just one specificity of this project along the Thai-Myanmar border in Mesot. There are 2 NGOs who provide antenatal care services for refugees, migrants, mobile population. We do take women who are already pregnant. This is the segment that costs us the most. We do that to sustain the NGO services. We do not have that option in Malaysia. In Malaysia, women who become pregnant are covered. We do not take now women who are already pregnant.
Thank you. Thank you very much, Nicola. And good luck. Time is up. Please, let's applause. Let's now move on to the second finalist. So Dr. Sadna Durvesh from Pakistan, with a project titled Empowering Last Mile Workers Through a Self-Sustaining Digital Ecosystem to Transform Reproductive Self-Care. Sana, you are online?
Yes, I am.
15 minutes. The floor is yours.
Thank you. Do you see me properly? Do you see the presentation?
Yes.
Okay. Hi, I am Sana Durvesh from Pakistan. Based out of Islamabad, it's around 6:30 p.m. here. and I'm very excited to be with all of you. I'll be presenting my project called Baji Connect, which is empowering Pakistan's community health workers with sustainable livelihoods so that they can continue serving the communities they have been serving as a backbone for several years. I represent Greenstar Social Marketing, the organization that has initiated this project. Greenstar Social Marketing is an NGO in Pakistan and it's been serving Pakistan for the last 35 years. I would like you to meet Samreen. Samreen is a community health worker trained by Greenstar, and she takes care of 200 households around her. She provides basic nutrition counseling, products sometimes, diarrhea management, family planning, reproductive information, connection with referrals with healthcare providers, and a very critical component is maternal and child care. But Samreen herself cannot take care of her family because she cannot make the ends meet. And this is unfortunately with most of the community health workers in Pakistan, except some that work with the public health sector. So as a context, there are 90,000 community health workers called the lady health workers in the public sector. Some of them are regularized, so they have a decent income, but the rest have patchy stipends. And similarly, the donor-funded NGO programs that have trained community health workers, they lose income when the donor programs end, and then there is a loss of the whole momentum that was created. The critical concern is they lose livelihoods, and so they move to other sectors. This is concerning because a lot of time and effort goes into their training and deployment and making sure that the community trusts them. They also have no connectivity with any digital opportunity to start their own entrepreneurial or employment, the way they like. And so what happens is when a community health worker cannot sustain herself, we lose quality care at the level of the communities. Now, how do we solve this problem? Pakistan has a digital connectivity boom and mobile penetration has increased. What it has given us is the opportunity that now women who were excluded from being connected, networking from digital tools, financial tools, entrepreneurial trainings, opportunities can now be included. On the other hand, in the private sector and other NGO sector, employers are looking for trained female healthcare workers who can provide trusted outreach. And these include pharmaceutical companies and other healthcare infrastructure, FMCGs, research companies, service-driven companies, for example, those that provide childcare and elderly care. So there is this opportunity here in the sector. So what is the big idea? The big idea is called Baji Connect. Baji means sister, and we call CHWs Bajis out of respect, like an elder sister. Baji Connect means connecting these Bajis with each other and with opportunities so that they can earn a decent income, at least a minimum wage that is prescribed by the law, and making sure that their households and their health sustains while they serve the communities. So the model is really simple. Like all community health workers around the world, they go out in the community, they do health education sessions, sometimes they provide basic products and basic services referrals. So they're a key backbone of the community health service. In our model, they're also connecting women to the telemedicine services that are available not only through Greenstar, but also other telemedicine partners completely free of cost, and also to the clinics around them, public or private sector. So there's a whole brick and click model available for communities. Now we needed to test this proof of concept, and we are very thankful to the British Asian Trust that gave us a little support in the beginning to establish the app and the website. And interestingly, in the very first month, 4,500 community health workers, mostly from the NGO sectors, trained through NGOs because they had lost their income and jobs, they signed up. But we had only enough resources to train 150 on social entrepreneurship, on use of digital tools, and giving them seed money to create a small micro enterprise, or connecting them to employment opportunity. And what we saw was there was a 2.5, average 2.5 times increase in their monthly income. We signed 10 MOUs with organizations that, preferably would hire through Baji Connect, these community health workers, making sure that the employment is close to their community and they stay within their own area, so that the real work that they have to do, provision of continuity of care, healthcare, can be done. We also secured social impact grants from the Deutsche Bank and from the Grand Challenges Canada, which helped us, create an ecosystem, market the solution, and making sure that we partner with more employers. We also had an MOU with the Benazir Income Support Program. This is a social protection program for people living in poverty, and they are now interested in graduating their beneficiaries into micro enterprising solutions, into creating employment, so that there's the dependency is reduced and they can stand on their own 2 feet, not depending on social protection forever. There will be a component, but then they also are including, they call it hunar, which is the Urdu word for small size micro enterprising, with whatever these community health workers are comfortable with. During the proof of concept, we saw that since our Bajis, our community health workers, were now more satisfied, their presence improved, the quality of care improved, and an independent evaluation showed, that was also sponsored by the Grand Challenges Canada, that the community's knowledge on self-managed healthcare improved from 8% to 94%. This includes knowledge on how to have a healthier lifestyle, better nutrition, diarrhea protection, infectious disease protection, care of the pregnant mother, lactation care, the whole 1,000-day journey. And we also saw that the beneficiaries, the satisfaction of the community health workers is reflecting among the beneficiaries in terms of their satisfaction improving from 73% to 99.9%, because now they were giving more time and they were more engaged with the communities. One thing that also helps is when they create a micro enterprise, they work with from their home and the community women come to them. So they're also earning a decent livelihood with that interaction, selling small products with whatever basket they have created, but they also get a chance to talk about health concerns, and connecting them, any woman who needs service, to telemedicine services. So the impact theory is very simple. We register, onboard, and train community health workers, our Bajis. We give them employment opportunity or entrepreneurship, whatever they choose. If they choose to be entrepreneurial, we give them seed money, and they create their own basket of goods that they sell. Sometimes these include health products. This results in sustainable income for community health workers, and that results in their improved presence and care at the community level. How will we sustain this? We have not yet pivoted to the partner subscription fees. We will do it in the next 1 year. Right now, because this is a new approach, we want to build the trust of employers, both organizational and individual employers. Individual employers who will use the community health worker services for perhaps child care or elderly care, because there is no such system in Pakistan, organized system in Pakistan, to provide these kind of services. So the partner network, the employers will pay a subscription fee, which will be used to run the operations and the platform, and will be reinvested. When we launched this program, it was in 2024, and the scale-up plan for the next 3 years, this is the organization's scale-up plan, is to onboard 2,500 more community health workers, and making sure that these are now 7,000 community health workers covered. This number comes from the fact that we are preferring those who were trained by Greenstar itself, because after the government, Greenstar has the largest network of community health workers from the NGO side. We aim to have 2,500 micro enterprises being led by these community health workers and generate $300,000 in terms of social impact grants. These are not the revenues we are counting right now, social impact grant so that we can create a whole system. And we onboard 100 employers who work with our community health workers in providing them employment. And the bottom line is the plan is that each community health worker must be able to earn the minimum wage set for that year so that they can sustain their family and their well-being.
Sana, you have 5 minutes.
Okay. Your support will help us reach our goal in terms of we will train 100 community health workers, make sure that these have either the micro enterprise or employment. These in turn will reach 720,000 women and girl beneficiaries with reproductive and maternal child health care services, allied services, and they will be earning a minimum wage. We will divide the award money 40% into operations and technology upgrades. We want to add an e-commerce platform into our website so that the platform generates its own income by sales of products. This is not the products that the community health workers will sell. These are the products that Greenstar will create, and they will include handicrafts, other materials these community health workers want to sell through the community, through the platform. And then 60% will be used for Sitara Bajis, these Bajis, community health workers training, creating micro enterprise for them, giving them seed money, product baskets with whatever they design. By 2030, we believe that community health workers trained by the Baji Connect will be happy, retained, and they will empower 2 million women on maternal and child health, reproductive health, and self-care. That will make health a community-owned movement and will contribute to achievement of Sustainable Development Goals 3, 5, 8, and 10. These are some of the partners. We are very grateful for their trust when we were just starting. And we believe that women sustain their livelihoods. When they do that, the community sustain their health. I would give a very brief sneak peek into the website if you would allow, if I still have time. This is the website.
Yes.
And these are the listed services.
We cannot see the website though.
Okay.
We can only
So
see the
I'll just stop. Okay. I'll move. Do you still see the presentation though?
Yes, we see the presentation,
okay,
not the website.
So okay. So I'm very happy to answer any questions that you may have. You must be having.
Perfect.
And thank you for your attention. Yeah.
Thank you, Sana. Thank you very much. Just give Sana a round of applause. Okay. Jury members, Julie online, or jury members here in the room?
Yes, thank you.
Julie?
Thank you
Yes,
so much.
please.
Thank you for the really excellent presentation, which complements, the application had a lot of information, but I found out a lot more from, the live presentation, including the picture is wonderful to see. So my question is on the types of medical interventions that the Sitara Bajis are undertaking and the level of training that they get in terms of medical procedures, because that could be a potential risk. And also, I understand that they work from their homes, so maybe in terms of sanitary conditions in the home and performing medical interventions, just to let us know what is the kind of due diligence and training that you do on that, and what's the kind of their remit in that sense. Thank you.
Sure. So Greenstar has a training and quality assurance department, but the basket of services that these community health workers provide is only those that are prescribed by WHO as the self-care basket. So they're not giving any other clinical services. When we say self-care, it is mostly pregnancy testing, height and weight management, identification of danger signs, connecting them to telehealth, clients to telehealth, connecting them to clinics, accompanying them sometimes if that is needed. So the whole self-care ambit, nothing outside that. The training involves 3 to 4 days of the subject matter training. It then also is a field level training, and the quality assurance department frequently visits and monitors them. But the key point remains that the healthcare services are still being given by the telemedicine partners and the clinics, not these community health workers.
Thanks for the clarification.
Thank you. Thank you.
Who'd like to go next? Yeah, Kiran?
Great presentation, Sana. I had questions along the same line as well around quality. while it's very tempting to rely on community health workers, sometimes quality can be an issue. And you do mention that there's a quality team going after this. My concerns arise out of your attempt to try and blend micro enterprise along with service delivery. And sometimes that can create conflicts of interest. What kind of goods are you selling? Are these women pressuring their customers and beneficiaries to buy these products? Are they giving wrong information? Has that been a problem? Have you had to weed out bad actors? Is there some sort of a public certification process? Like, do these people, service providers, do they have to be registered and approved by the government? Can you expand a little more broadly on quality assurance, please?
Sure. So thank you for that question. And that has, I would be very honest that even with the service provider network, the trained, licensed healthcare provider network, since it's a franchise, we have to do a lot of due diligence to make sure that they stay on standards. But coming back to community health workers, you're right that the product basket can create a conflict of interest. Interestingly, they do not often pick health products. They pick, for example, from the previous pilot, they pick sometimes household items, sometimes, soaps, detergents, those kind of things, because they're easily sold. The only health product that they have been selling is ORS and zinc, which is not sometimes, which is not something that is when overprescribed would create a problem. And the sanitary napkins. So that is a regular need of the community. That is the product basket. Greenstar has their own product, but we do not give it to them because there's a regulatory requirement. They cannot sell health products, pharmaceuticals. Now, the quality assurance system, because right now there are only 150 trained that we are owning, it is easier to manage them, the continuous check. When the workforce will expand, we will definitely need this kind of, and we are already in conversation with the provincial health departments to take them under their umbrella in terms of just monitoring and taking their data. Because only when they will share data with the government, then their performance will become visible. Greenstar can go on saying these many services were provided, but when we integrate, and this is where telemedicine will help, that we can integrate the data coming from these workers with the government system. This is an ongoing process, and we are very vigilant about this. It has happened in one of the province that some data has started going into the DHIS referral data, but education data also, and also making sure that government's own monitoring and supervision is done, like the LHW program. They can also extend it to these community health workers. Thank you. I hope that answers the question.
Thanks so much for your great presentation. Please correct me if I'm wrong. This project is for community health workers to find second income source through Badge Connect?
Yes. For public health, community health workers, this is a second income source. For those that were trained by NGOs and the donor programs have ended, this will be their only source of income. So it has to meet the minimum wage requirement. Yeah.
Thanks so much.
Yeah.
Thank you, Jean-Louis. Oh. Questions from the audience? Feel free. Any curiosity? Anything which is not clear? No? Yeah.
If I can, oh, you found one. If there's time later, I'll add something, but otherwise, please go ahead from the audience.
We'll have a few minutes so we can get to questions, definitely.
Thank you so much. Two questions, a little bit, but both sort of in the vein of scaling up in your longer term vision. One is how and whether you're sort of seeing this connect with the broader CHW direction for Pakistan. And also, yeah, just thinking about sort of sustainability of some of this work as you go to a bigger scale. What are some of your questions, concerns, things that you're thinking through to really make that work?
Thank you.
Julie, do you want to continue your question? Sana, do you mind?
No, please go ahead. Please go ahead.
Okay. Sana, please.
Okay, so in terms of the broader connection with, like I said, we are in conversation with the government to take them in their ambit. Government is struggling with keeping the LHW program alive right now, and they're not inducting new lady health workers. In the biggest province of Punjab, they have actually started laying them off. So for us, the domestic financing, the private sector financing, the resources that are already there is a huge sell for the government that they only have to give it ownership. They only have to give it supervision, and we can create that workforce for them. They only need to make sure that they're sharing the data, they're monitored, they're supervised, and the whole system runs on its own through domestic financing. Employers are paying for services, products are being sold by CHWs, so they're making their own income. We are very grateful to the Grand Challenges Canada that we said we will implement the program. Greenstar has put in a lot of its own internal resources into this. We need to create evidence, very good quality evidence. So we are doing 2 studies side by side, making sure that this model is actually the livelihood improvement is leading to better health outcomes in the communities. 1. Number 2 is actually the knowledge of self-care, community self-care improving. So these are 2 studies that are simultaneously happening. And I think once this evidence is documented, we can go to the government and we can say this model works and it reduces the burden on the public health systems. It also reduces donor dependency. Let's adopt it. Now, my hope is with Sindh province, it might be an easier uptake. Some other provinces might be slow, but this is our understanding that when Sindh adopts, other provinces follow.
Thank you, Sana. Julie, do you still have a question?
Yes, thank you. It was just in terms of the profile of the Sitara Bachis, how these people are, identified, or if you sometimes have more than can, how you choose who you're going to work with. Thank you.
Okay, we announce through whatever donor program used to come in, we used to define an eligibility criteria with the donor. The basic one is they have to be literate, matriculate, so that they can write, read, understand the local language, and it's preferable that they also understand the national language, which is Urdu. English is cherry on the top, but not a requirement. So the basic literacy and respect in the community in terms of people, recognize this person, welcomes this person in the community, and this is a well accepted person by the community. So community helps us identify. We go to the community, we say this is the requirement, this is a program, you tell us who's the best suited. They give us a pool, we interview, and then they go through extensive training on whatever health area they're working on, mostly family planning, maternal child health, but more recently on mental health programs as well, and diarrhea management programs and infectious disease programs also. So there's a whole training. The training is given by Greenstar, and the training program is endorsed by Punjab government, which is one of the provincial governments. We are striving for the endorsement from other provinces also. But we are going to add elderly care training programs and child care training programs so that their service basket increases. So to answer the question, community identifies them on a set eligibility criteria, and then we see whoever's the most confident and upbeat, to go in the communities and so.
Perfect. Thank you very much.
Thank you very much, Sana. Time is up. So please, round of applause for Sana again. And good luck.
Thank you.
We're now moving seamlessly to the final finalist for the day, Henrique Santos, do Instituto de Inteligência Artificial na Saúde, from Brazil. For the project, it will be presenting the project NoHarm.ai, artificial intelligence to improve patient safety. Henrique, you have 15 minutes.
Spoiler alert.
spoilers. Can I start? Should I start?
Yes.
Good afternoon, everyone. Yes, I'm from Brazil. And the city I came from, it called Happy Port. So you can imagine. So nice to meet you. Thank you to have you all here. I'm very glad to be at the finals of most innovative development project. Very happy to meet the other projects from Sana and Nicola. It's amazing projects. But I'm here to tell about NoHarm. It's a system that we developed in Brazil to keep patient safety in healthcare environment. Not only hospitals, but also primary care. But here we are going to show the project for hospitals, but it still works in primary care. And I am co-founder and CEO, and you need to meet my other co-founder, Ana Helena. So we started this project in 2018, and we are brothers. Ana Helena is a PhD pharmacist and a PhD in computer science. And we start a project to develop AI algorithms to keep patient safety in hospital environments. Because Ana Helena works in a 1,000-bed hospital, public hospital in Brazil. It's a huge hospital in our city, and she struggled to evaluate the risks of the patients in the treatment during the length of stay. So you wonder to develop algorithms to keep the patient safety. Because as you may know, the healthcare system is broken. Not only because the costs that is rising, but also because of the healthcare workers that are burning out. And during the COVID pandemic, it made clear to us that it's happening, but it's still happening. And in Brazil, we have one of the largest healthcare system in the world. It's public and it's for everyone. And so if one of you go to Brazil, you are going to be covered by the Brazilian public health system. But more than 200 million people rely only on the public health system in Brazil. And as in other healthcare systems, we have problems. We have errors that happen to the patients inside the hospital and also in the primary care. That is going to damage the patients, could lead them to death. And we need to understand the kind of errors to prevent and avoid these errors to keep the patient safety, not only on the hospital environment, but also in the primary care. And just to let you know the percentage of errors that happen in these environments, the primary care is the major side that have errors, but also it happens in the hospital care, in the tertiary care, and even in the ICU of neonatal patients happen errors. So it costs for all the system, not only in Brazil, money. So if we are able to avoid this kind of errors, we're going to decrease the healthcare costs overall. And this is why we built NoHarm.ai. It's a healthcare system that is going to monitor all the data of the patient inside the hospital or primary care to identify these kind of risks and highlight it for the healthcare workers to try to avoid the risks, to prevent this kind of damage to happen to the patient. But we did not going to replace electronic medical records. We needn't. We need that the hospital and the primary care has an electronic medical record. NoHarm rely on this kind of data to run the algorithms. It will show and alerts to the healthcare professionals these kind of errors to avoid and prevent. And this is a risk management system that is going over on the top of the EMR, electronic medical records. We're going to gather the information, monitor it, and alert the healthcare workers and healthcare professionals to show them where is the problem and how to avoid it. Not workers alert system, but to highlight and educate the healthcare professionals to how manage this kind of errors. and to improve care. And this is going to reduce the workload of the healthcare workers because they don't need to search for all the documents inside the hospital or in the primary care about the risks of patients, because we're going to highlight to them. And also, we're going to educate them how to handle this kind of errors. And this is going to reduce the workload, and going to improve the healthcare for the patient that is admitted in the hospital. And how it works, this is a pharmacist, one of our people that use our system. There is nurse, pharmacists, physicians, and nutrition that works using NoHarm. And so this is a very easy to use screen that is we are going to highlight the problems, highlight and prioritize the patient that have this more problems. And then we're going to ensure and to educate the healthcare professionals how to improve and to fix this kind of errors, to improve the care. And this is going to a screen that show all the information. So we already measured that is going to improve 4 times the efficiency of the healthcare working using our system above a EMR, a classical EMR. There is just a system that they register information. And we gather all the information of the patients. Clinical notes, prescription, laboratory exams, demographic information. We gather all this information, we cross this information with AI, and we're going to highlight the problems and highlight how to improve the care of this patient. And we developed several AI tools, several AI features inside of the systems. Prescription scores, laboratory exams, we highlight the out of reference. We developed a system with Gates Foundation to write down a discharge summary automatically. So the physicians only need to review the discharge summary for the patients. We have a system with natural processing language that's going to highlight the risks of the patient in the clinical notes. So the healthcare professional doesn't need to read all the clinical notes, all the things that happened with the patients. We also have antimicrobial stewardships that help the pharmacists about the usage of the antimicrobial drugs to avoid resistance of the bacteria. And also we have a database with drug-to-drug interactions. And this is going to increase efficiency of the healthcare workers, and the healthcare system overall is going to prevent errors, to increase the overall quality of the care for the patients. But most of all, that is very important for all government and all healthcare system, is going to reduce costs, because the system is going to improve the healthcare overall. In Brazil, we already deployed the system in 200 hospitals, and we only charge for the private hospitals, and the public one gets the system for free. So we are able to sustain our impact to the public health system using the private hospitals fee. This is a way to sustain and maintain our project, our social project, giving benefits to the public health care. And it's a recovering revenue that we charge from the private hospitals. And this kind of model, it's happened in other countries in Latin America and in the world. We have a public system and a private system. And this is going to enhance the quality of the healthcare provided, not only for the public health system, but also for the private health system is going to improve, because the system, it works equally in both systems. The only difference is that the private care pays for it. And we already impact 3 million lives in Brazil. And we did not impact only the patients, but we also impact the healthcare workers that is going to have a decreased workload. They don't need to search for all the information, and it's going to improve faster and with more quality using NoHarm system. Thank you. We monitor 50,000 beds nowadays. We saved $20 million in 5 years of the project in 200 hospitals in Brazil. So it's not only about quality, it's about costs, to reduce costs in the healthcare. And also with all of that, we are able to have a revenue of more than $500,000 in last year. So it keeps us giving our impact to the public health system in Brazil. Not only that, we are a research NGO. We not only operate the system, we are still doing research to impact and to change the lives of the people in the healthcare system. We are a group of researchers, not only me and Ana-Helena are PhD. We have a group of PhD, they are still doing research to improve our algorithms, to improve healthcare, to study how to improve the healthcare overall, not only with algorithms, but also with the improvement of the healthcare system, educating the healthcare providers. And we still publish our results in several conferences and journals. And we believe in open knowledge. So we not only publish our articles, but we publish everything we do as an open source system and open source model, AI models. So any one of you can copy any part of AI, of NoHarm.ai, license free, because we believe that it is going to impact more the healthcare. You can copy the slides. There is a link. You can download and copy the slides because we believe in open knowledge. And we already get several awards. Ana-Helena, our co-founder, was listed last month by Time magazine as one of the AI influencers of the world because of the projects that we deliver AI in Amazon. With the GDA, we believe that we can scale up it because we need grants to scale our project. We promise to keep it in the hospitals and primary care that we're going to deliver, but we need the award to scale our project in more hospitals and more cities. And with this project, we're going to benefit 80,000 patients a year, because we're going to keep it running after the grant, using the private care fees. And also we're going to improve the healthcare workers' job and routine with NoHarm. And if we scale more, we are able to deploy NoHarm in more than 1,000 hospitals, but not only in Brazil, we can do that in any other country that GDN has partnership. Because we believe that NoHarm can improve the healthcare anywhere that has electronic medical records, primary care or tertiary care. We are very proud of our project. We believe that here we can do more partners and to improve the healthcare in the world with open knowledge and with AI. Thank you so much.
Thank you, Enrique. Perfectly in time. Let's move to Q&A. Questions? Rui? Yes. You have questions.
Obrigado pela apresentação.
De nada.
Ótimo. Eu morei em Salvador, então no setor da saúde conheço. Anyway, thank you for the presentation. I was curious to know what the drivers of the effects, of the magnitudes of the efficiency effects of the cost savings. What are the main factors? So I assume that there's a difference between public and private hospitals. Is it the size of the hospital? Is it so what drives the cost savings? Where do you actually, because there are probably places where you don't get any cost savings and other places where you get lots of cost savings. So what are the determinants of the heterogeneity in cost savings?
Amazing. Yes, amazing question. Yes, and well, we intuitively think that public hospital is going to be different than the private one, and usually is similar. So what gave us the impact of the costs is more about the size of the hospital. And we are able to measure savings in all settings, because we save our saving amount of $20 million in 5 years. It's about efficiency, because now the healthcare professionals are able to review and to assess more patients. So it's about how is the earning of each healthcare professional, and we can scale this team without scale the size of the team. We can scale the benefits of this team without scale the size of the team. And you may wonder, so AI is quitting jobs? No, because the hospital doesn't have this money to hire everyone. So the hospital should need 200 nurses, but they have 100 only. So this is one of the cost saving, is to increase the efficiency of the team, of the healthcare team. The second cost savings is about drugs. High cost drugs that was prescribed, and we can change it for lower cost drugs. So, and sometimes we have some EV drug that could be replaced for a solid pill. So this is going to save costs. So this is the two major savings: increase efficiency of the healthcare professional and to change for high to low drug costs. And it happens in all environments. So we are able to save in any environment. A tiny hospital with 100 beds or a huge hospital with 1,000 beds, we can save money. Thank you so much for your question.
Thank you. Any other questions? Yeah, Mr. Ride.
Thank you for the presentation. I have one question: that if one patient you change the hospital, next hospital also keep the get the information of that patient through your application?
A very good question also, because it's what everyone wants, right? Every country in the world wants interoperability between settings: hospital, primary care, tertiary care, second care. But it's very difficult to do that. Who owns our data is the hospital, it's not us. So we are only able to manage and to run algorithms for the hospital. We are not able to split or to use this data elsewhere. Yes, we use data to teach the algorithms to learning, machine learning, but we cannot use this data to provide information to other hospitals. It's possible, but this is a problem to costs, so we can face, because we need to handle governments, we need to handle private and public sector. So we are in the beginning of a huge and large journey of interoperability. So we start with one hospital each at this time.
Thank you for the presentation, Hendrik. I have a few questions. First, starting with how you train your AI tools. I would want to learn a little more about what sort of information you use in order to train them. Are you using information from Pharmacopoeia, for example? Where are you getting drug interaction information? Where are you getting the rest of the information? I guess you need pricing information. What sort of, are you feeding research papers in there? What goes in there in order to feed your algorithm? What kind of data goes in there? You also mentioned something about you're doing something on antimicrobial stewardship. Do you have hospital antimicrograms? Are you just randomly picking antimicrograms from all over Brazil? Do you have hospital-specific data for there? Are you validating any of these tools? Is there external validation? There's so many questions I have.
Yes,
around these.
I can believe.
That one particular basket of question. The second basket of question I have around is scaling up. And I wonder if you have it the other way around. If you really want to scale up the way you want to, should you not think about just latching this onto an EMR that is extensively used in Brazil, use this as a feature set, and then it immediately scales up throughout the country? What appears to me as a business model you're trying to do here, you're trying to piece by piece create another EMR that you want to scale up all over, which I think would just duplicate efforts. Have you thought about scaling up on top of an EMR that's already used? What kind of EMRs are used in Brazil? Is it one EMR all over, or are there multiple ones? Have you any question? And the third, more of a concern, is you mentioned 99% errors, healthcare errors in primary care. I'm not exactly sure if you're being fastidious around those numbers, but that does not seem right to me. I don't 99% of what? That was not explained, so if you can explain on that.
Yes, this is an open number. Okay, 3 questions. Let me regard. Yes, I can answer these questions in 1 hour or in a week. Yeah, so I will try to be fast. So first question is about data, or how we use this data, when. So there is several algorithms. Most of them is trained using hostile data itself alone, because it's unsupervised learning and supervised learning over the data of the hostel. There's 2 algorithms that use all the hostel data. The first one is the risk that we detect in the clinical notes, because it's Portuguese, so we can use the same algorithms. But the one is prescription score, antimicrobial resistance, we use on hostel data itself. Second question, yes, we want that. This is why we develop open source. We want that someone copy it, and we can help. There is open MRS that is used in Africa in several countries, but we don't have the energy and people to do that. But we want that. In the primary healthcare in Brazil, we have one major system that is public and open source and free, that we want that this company develop the no harm strategy or pieces of no harm inside this EMR. But we need partnerships. They did not know that we exist yet. But we want that, because our mission here is not to dominate the market. This is why we put open source, because we want people copy us, and we want people put part of our features or all of our features in other systems to replicate our impact. The third one is what?
Errors.
Oh yeah, the errors. This is the prescription errors. And it is 95. There is an article cited the numbers of errors. But here we are taking errors like written errors, drug-to-drug interaction, dosage errors, frequency errors, timing errors. You should take this pill at the morning, but the physician put at the night. These kind of errors are super common. So if you wonder errors of any one of these, is 95%. In the hospital, 75. In the ICU neonatal, 45. Thank you so much.
Thank you. Julie, would you have any question? Yep. Can you unmute?
Sorry. I was looking something up. So yes, my question, thank you for the really great presentation. I learned a lot and really impressive. My main question is about the vulnerability profile of the patients that you're reaching with these interventions, because in the project document, in the application, I couldn't find much information about, if these are public hospitals, are you targeting hospitals which are with the award funds, whether you would target hospitals that cater to more vulnerable populations, or these could be a public hospital in a rich neighborhood. So I just wanted to get an idea if there's any kind of, hospital eligibility profile or patient profile that goes into your decision of which hospitals to expand to. Thank you.
Amazing. Thank you for your question, Julie. We are open to discussion because we have a list of 500 pending hospitals to integrate with no harm in Brazil, only public. And we need funds to do that. And these are hospitals spread in all Brazil, in countryside, in main cities, in rich neighborhood, poor neighborhoods. It's in the Amazon forest, in the northeast of Brazil. you can pick whatever you want, because we have all size and all type of hospitals. And we are not able to deploy NoHarm in all of them because we don't have money and size of team to do that. So we need funds to spread NoHarm to Brazil or to partner with other providers. We don't want to be take advantage of all the marketing. So if you as GDN have partners, so we can get advantage to deploy NoHarm in existing systems, I think it's the best strategy than to dominate the market only with one company. So you can pick the 25 hospitals from a list of 500. Thank you.
Thank you, Enrique. I think time is up. So join me.
Thank you.
A round of applause for Enrique. Great. So this is the end of the finals for now. And now the jury will move to the jury meeting, where we'll be discussing the projects, how many awards will be awarded, and what the ranking will be.